Good evening to all optometrists, ocularists, occupational therapists. What else is there? All of you. And a very special welcome to Dr. Khantsi tonight. It's the first time that he'll be doing a Zoom webinar for us. Dr. Khantsi, welcome.
Thank you.
I would like to just mention that Dr. Khantsi, as you might have just seen, has a practice in Midrand on New Road in the Colesveld, behind the Colesveld Centre in the HealthWorks Medical Centre. And he also has a practice in Bank City in Joburg CBD. So welcome, Dr. Khantsi. It's a pleasure having you on board.
Thank you.
Thank you, Dr. Khantsi.
Hello, everyone. Good evening. I'm sure you've all had a fairly busy day, and to come and listen to a lecture at this time of day is a bit of a challenge. So I'll try and keep it light and try and talk about things that are very relevant to you, things that you sort of see every day. So before I start, my name is Boitumelo. Everybody calls me BK. I did my undergraduate at University of Pretoria, postgrad at Wits, so I was in the Wits circuit. I did training in retina, surgical retina, and medical retina thereafter after my registrar time. But today's talk will be general anterior segment. It will be things that you sort of see every day. It will be things that matter because patients. I always get patients who complain with or who present with these complaints. Okay. So we'll start with a talk as soon as technology lets me. Right. So. Common complaints which have always stumped me initially when I started private practice, because these kind of patients you don't really see when you're training in state because their problems are not considered important. But essentially we're talking about photophobia, night vision problems, and headaches. And we'll talk about each one in turn. So night vision problems, night driving problems, sort of it falls all under the same or similar term. So we'll start with a case study. So I had a 40-year-old female. She told me she avoids driving at night because she can't see, and it had been like that for a while. She had been wearing spectacles since 2000. She didn't have the script with her, or there was no prescription on her referral note. She was referred by her usual optometrist for worsening night driving symptoms. But now she had severe photophobia. She wouldn't open her eyes at all. On clinical examination, her uncorrected visual acuities were 6.9 in the right eye and 6.19 in the left, and then they corrected to 6.6 on pinhole. There was really nothing much to see on examination of the eyelids. They were both normal with no signs of blepharitis, which is one of the first things you should look for in patients who complain of night vision problems. The conjunctiva were normal in both eyes, and I spent quite a lot of time examining the corneas carefully in these patients. So this patient had mildly reduced tear breakup time. She had no fluorescent staining. She had no prominent corneal nerves, no corneal scars, negative Munson sign. So in my mind, the back of my mind, I'm thinking this may be keratoconus, given the duration of the symptoms and the suddenness of the symptoms worsening. IOPs were normal, 15 millimeters of mercury, both eyes, so there's really nothing there. And then I dilated the patient and decided to do a dilated fundoscopy. And this is what I found. So the fundus itself was normal. So the optic nerve was normal, or optic nerves were normal. The vasculature was normal, and the maculae were normal. However, she had these cerulean, or otherwise known as blue dot type cataracts, which she probably had since birth, because they're generally congenital. For completion, I did a pentacam on this patient, looking for corneal pathology again, and it was really unremarkable. Right. So before I talk about cerulean cataracts and approaches to this and the pitfalls, it's important to differentiate between a patient who says, I cannot see at night. In other words, true nyctalopia, which is a retinal problem, and it's quite rare, versus I have glare. So cars' lights blind me, or they see halos. And patients who have contrast sensitivity problems, patients who can't differentiate shadows or shades of gray and black, they're generally unhappy in low light conditions. It's important to elicit some sort of family history of similar problems, because that may point towards a retinal problem, potentially keratoconus as well, so a corneal problem, but corneal dystrophies can also present like this. So potential causes of night vision problems, we already mentioned corneal abnormalities. The most common one would be dry eye syndrome, blepharitis. These are very common. And also always look for signs of keratoconus. Hence, I mentioned those things that I look for in this patient's corneas, like dilated or enlarged corneal nerves, any scarring, any Deschamets stria, and things like that. Lenticular problems are often missed, and I'm going to talk about that just in a minute. Inflammation, you'd be surprised how many patients would present with a uveitis, sort of indolent uveitis, so low-grade type uveitis, where they do not have the typical red eye and pain. And they complain of either blurred vision or glare or night vision problems. And when you examine their eye, you see they actually have an active anterior chamber, and some of them have roaring uveitis, which had been going on for a while. Depending on the cause, or obviously underlying cause, they may not always present classically, and I've seen it several times. Dry eye syndrome I've already touched on. We're not going to belabor the point. And retinal dystrophies, it would be more sort of rod cone dystrophies. These are extremely rare. They usually, patient will know that they have family problems or family eye problems, or eye problems in their families and extended families. So they will sort of volunteer this fact almost upfront. Okay. So this patient, you saw the blue dot cataract. The tricky bit was that her uncorrected visual acuities were fairly good. But I counseled her when we opted for cataract surgery, and post-operatively, the symptoms had resolved. She could drive at night now. She was 6'6", uncorrected, both eyes. and she was plus 0.25, and plano in the other eye, no issues. Now, the point I'm trying to make here is, if you look at the image of the blue dot cataract in your top left-hand corner, you'll see that if you look at the lens while the pupil is not dilated, you're not going to notice that there's a lenticular opacity there. Some of them are quite subtle. And it takes not only dilated fundoscopy, but also examining the lens carefully under high magnification. The other fairly common thing is the vacuoles, which occur in some people. Many people have these vacuoles in their crystalline lenses. They usually don't cause issues if they're not in the center, but patients with these vacuoles in the center can present with night driving problems. They can present with contrast sensitivity problems. So they may have normal vision and they may come to you for spectacles. You may well dispense spectacles, and they're usually sort of unhappy and then come to the ophthalmologist. And when you look at their lenses carefully on retroillumination, you'll find these subtle vacuoles everywhere, and that's an indication for cataract surgery, and patients tend to do well thereafter. Right, so let's go on to photophobia. So the term photophobia is a bit of a misnomer, really, because it really refers to phobia of light. I think the only things that I would have phobia of light are like vampires or something. So nocturnal type creatures, those will have phobia of light. So patients have intolerance of light or are intolerant of light. So the patient I saw was a 36-year-old office administrator. She complained of sort of not so good vision in both eyes for a while, but brightly lit areas seemed to bother her more. It had started 3 years prior to her coming to see me. And at the time she was given spectacles with a tint, and this seemed to solve the problem a little bit. But as time progressed, these spectacles weren't helping anymore. So she presented to her home regular optometrist in 2019 for worsening symptoms. I didn't have a habitual script on hand, but the patient had brought a pair of sunglasses with her. And she proceeded to tell me that she sees better with the sunglasses on than with her prescription spectacles. And this has nothing to do with the amount of light, really. She felt like the sunglasses were acting like a prescription lens for her. That's how she described it. On medical history, she has generalized anxiety disorder. She's one of those patients who are unsettled, they're a bit nervous. She was there with a boyfriend, I assume it was a boyfriend, who she kept referring to about all her symptoms. She had no significant medical history, and her hobbies were only just reading. The ophthalmic examination, uncorrected visual acuities were quite bad. So it was 6/120 in the right eye and 6/190 in the left eye. Initially, I thought she was faking this because, you know, she was acting up, moving forward, backwards and forwards, side to side on the slit lamp. She kept saying she can't see, she can't see, she can't see. You do pinhole testing, there is no improvement in visual acuity. The eyelids were normal, the conjunctiva were normal. There was no real pathology on examination of the corneas either. There was no obvious stromal thinning. There's no obvious abnormal steepening. There's no corneal scarring at all. The crystalline lenses were clear in both eyes. And fundoscopy, there's nothing to see really, significant to see. The optic nerves are normal with 0.2 vertical capital disc ratios. They had healthy neuroretinal rims, and the retinas look normal in both eyes. So now what? You have this patient, examination is more or less normal. What do you do?
webinar. Ek is die host hoor.
So
Mos
I
kyk by
referred the patient for a pentagram because an anterior segment examination with a suspected corneal pathology is not complete until you do corneal tomography, not only topography, but corneal tomography. I won't stay too long on this slide simply because I just want to show you the summary of the slide, or the summary slide. So she had fairly steep corneas. She had thin stroma. And as you can see, according to the Crimmage staging of keratoconus, she had moderate keratoconus, which had been missed all along when she had been going to her regular optometrist. So just a quick word on keratoconus. Remember, it's classically described as having corneal stromal thinning, no inflammation. There should be no vascularization of the cornea, and the thinning should be central or paracentral. Remember, there are more than one type of corneal ectasias. There's keratoglobus, pellucid marginal degeneration, which usually occurs in older people. And in the era of LASIK and PRK, you can get post-refractive surgery ectasia as well. I just want to spend a little bit of time on keratoconus. Just remember, it's a fairly common condition. It's usually bilateral. It may be unilateral. What's important is they may have other diseases associated with their abnormally shaped corneas. So I almost always intensively interrogate patients for symptoms of allergies. So any itching, discomfort, current or past, and go into their medical history if they're minors, children with their parents. Patients do not always realize the significance of their other diseases in relation to their eyes. So I go into detail about trying to exclude all these things, because some of these disorders can be life-threatening if they are missed. Right, pellucid marginal degeneration. They usually have inferior or superior corneal thinning, corneal stromal thinning, but the bulge is above the area of thinning. So it's unlike keratoconus where they're thin and then they bulge more or less in the same area of the cornea. They're usually bilateral, they may be asymmetrical, but I see about, say, 2 of these a year. And they're terrible cases to manage because there's not a lot to do for them except give them contact lenses, potentially hard contact lenses. Keratoglobus, not a common condition. It's thought to be a variant of keratoconus, but the cornea has no focal areas of thinning. So the whole cornea is enlarged and the whole cornea protrudes. So giving the cornea a globular type configuration. I have one patient with keratoglobus. He's about 19 years old now. I cross-linked him last year because he presented complaining of deteriorating vision. And he did quite well after corneal cross-linking, and he's using spectacles and not contact lenses, and he's quite happy. I think his vision now is about 6.9 in the right eye, which was the more severe eye, and in the left eye it's 6.6 with a correction. Right, so please remember, not all bulges are keratoconus. Tomography, if you suspect any corneal pathology, I would strongly suggest that you send patient for tomography, topography if you don't have one in your rooms, and always set patient expectation with keratoconus. When you send them to the ophthalmologist, don't tell them you're sending them for them to see. You're sending them to stop the progression of the diseases. They're coming back to you for visual rehabilitation. Okay, we're not going to go into detail about evidence for the use of corneal cross-linking, whether this thing works or doesn't work. It's a very long, controversial topic that. Right. Let's talk about headaches. Now, headaches are a headache for me, a headache for the patient, they're a headache for everybody. They're a headache for some of my colleagues I would send these patients to. And for some reason, people believe if you have a headache, it's probably an eye problem. It's as if it's a knee-jerk reaction to headache. It must be your eyes. Right, so I had a 14-year-old female who was brought in by her mom. She had complaints of frequent, recurrent, sort of frontal headaches, so around the forehead area. And they sort of extend to the eyes. She's not too sure, but she thinks the pain extended to the eyes. Sometimes she thought she had ocular pain instead of headache. Hence, she presented to an optometrist. But she also complained of vague body aches and chest pains and things like that. She had no significant medical history. She had been wearing minus 2.50 with no cell correction for the past 3 months. And the patient claimed that initially the spectacles seemed to work. After 3 months or so, the headaches recurred and she presented back to the optometrist. Hence, the optometrist sent the patient to me. So on examination, her uncorrected visual acuity was 624 in both eyes. With the current script, or the script she was wearing at the time, it corrected to 6.9 and 6.12. By the way, she pinhole slightly better than that to about 6.7 in both eyes as well. Auto refraction, I didn't do a formal refraction on her. It was minus 2.25 and minus 2.5 and with no astigmatism whatsoever. Essentially, there was not much to find on examination of the ophthalmic of the eyes. That is, the eyelids were normal, the conjunctiva were clear, the corneas were clear, the anterior chambers were deep, they were quiet in both eyes. The pupils were nice, round, and had normal reaction to light. The lenses were clear, the optic discs were also normal. The retina was also normal, the optic nerves were also normal. I expected to at least find some swollen discs, I was hoping, but I was disappointed. There was nothing there whatsoever. Now what? What do you do with this patient? Well, anybody who has unexplained reduction in vision with an added cranial symptom, I send for neurological imaging. So patients with headaches and eye problems that are the headaches that are not relieved by wearing spectacles, in some cases, I often send them to a neurologist for neurological imaging and further investigation. Now, what are the ophthalmic causes of headaches? The legitimate causes of headaches. So refractive error, you guys know that usually they're hyperopic patients, and the high hyperopes will frequently present with headaches, and hyperopia has been associated with a higher frequency of migraines as well. So accommodative spasm patient will usually have an esotropia, sudden onset, unilateral frontal headache, blurred vision, and a myotic pupil on that side. Astinopia is also one of the more common causes of headaches, or patients ascribe the discomfort as a headache and not eye pain. Convergence insufficiency is an important consideration, especially in older patients. This is fairly common, so always just make a habit of, if an older patient complains of frequent headaches, of checking their near point of convergence. If it's above 10 centimeters, then maybe they should do eye push-ups. Ocular inflammation, I'm not going to go in too much detail into that because usually they will be easy to see. Acute angle closure glaucoma. I had a patient today who has had a headache for the past 6 months since lockdown. and she was diagnosed with cluster headaches and given painkillers. And she actually had acute angle closure glaucoma. Her pressures were in the 60s. So, you know, it's always worth your while to check their pressures and look at their pupillary reaction. Optic neuritis, one of the dead giveaways, obviously, is the presence of a relative afferent pupil defect, an RAPD. And they generally have pain on eye movement as well. So that may suggest an optic neuritis, and they need to have an MRI as soon as possible. So the non-ophthalmic causes of headaches. So these of headaches that we will see often. So migraine, remember there's two types of migraine. So you have your classical migraines where the patient will describe an aura, so scintillating lights, multicolored lights, or an enlarged blind spot, or a scotoma. We call it a marching scotoma. It's a scotoma that starts, it sort of blooms, gets larger, and slowly gets smaller. So they may have poor vision with this, hence they may present to optometrists. Tension headaches and cluster headaches, these are fairly common. It's a difficult diagnosis to make. I generally send them to a neurologist to make the diagnosis. Sinusitis, patients who are generally allergic. Acute sinusitis is fairly uncommon. They usually present to their GP before they present to you, and they usually get treated, but do not underestimate its frequency, because these patients feel, and they always describe the feeling of, it's a headache, but they also feel pressure behind the globe. Remember, the sinuses are close to the eyes, so when they have sinus problem, they may get eye discomfort as well. Hypertension, high blood pressure can cause headaches on its own if it's uncontrolled and it's very high, but also antihypertensives can cause headaches. So patients who are taking calcium channel blockers, for example, are more likely to get headaches than on other treatment for hypertension. So these are the important things that I would ask a patient. We'll go through all these. In the end, when you find nothing, like in my patient, the 14-year-old, I found nothing, excuse me, that's not supposed to happen. That's better. We couldn't really find any organic cause for the headache. So I gave her a course of lubricants and I sent her off to a neurologist. She hasn't come back from the neurologist, and I haven't received any feedback from that. But I suspect she has an intracranial problem, given that the eyes themselves look normal and the headaches are serious enough to wake her up at night and for her to want to miss school. So those are generally signs of something serious in a child if they wake up at night and they don't want to go to school because of the problem. So these patients I see a lot. I see them from GPs, from optometrists, and in the COVID era where people work on backlit screens a lot, they will always complain about having to work in front of a screen and it causes them headaches, etc., etc. Just don't dismiss it as just a functional refractive thing. There may be other causes of these headaches in these patients, and there's a lot of them who present with us. I think that was my last slide. Thank you very much. Over to you, Louise.
Okay, can you guys hear me? Okay, I just want to double check. Can you hear me? All right, thank you. Doctor, I just want to quickly go to the question and answers. Okay, there's no questions at the moment. There was one chat. The question was, why would you check for blepharitis if a patient complained about poor night vision?
You got to remember the tear film is an integral part of the refractive system of the eye. And you remember that the tear film consists of 3 layers. So you have your aqueous layer, you have your mucus layer, and then you also have your lipid layer. So patients with blepharitis would have a poor quality lipid layer. So they have unstable tear film. So when they're driving, and remember, under scotopic conditions, the pupil dilates. So what they have is an unstable, abnormal tear film, which is an integral part of the refractive system. And if they're not treated, they're not going to get better. So you have to treat their blepharitis. If there are any signs of blepharitis in a patient, especially when you find nothing else. If the cornea looks normal, in general terms, I mean, excluding the tear breakup time and all, if the tomography or the topography is normal, and if the optic nerve is normal, it's important that if there is a presence of blepharitis, that you treat them for that. And you'd be amazed, they'll come back 3 months later and with minimal symptoms thereafter.
Thank you, Doctor. There's one question. I just want to check, Jenny Sydney, you've raised your hand. That's what probably had to do with the sound, I presume. Just want to come out again. Motabang has asked, what would be the cause of diplopia associated with persistent headaches, and how would you treat such a patient?
Right. So one of the causes, non-serious causes of diplopia with a headache would be an accommodative spasm, but that's usually acute. But you have those patients who sort of cycle. In other words, they have episodes, it may last 2 hours and it resolves by itself. So during the acute episode, when they have the accommodative spasm, which includes esotropia and pupil constriction, they tend to get double vision. Right, now, double vision plus headache in general should have neuroimaging, almost always. It's almost always a brain problem, so to speak. Either functional or organic problem, which must be excluded.
Thank you. The lady had some sound problems. She just wants to know again, what was prescribed to the headache patient?
I generally do not prescribe patients pain relief for headaches. I refer them either to their GP for that or to the neurologist. Now, it's usually very difficult to get a neurology appointment. Most of them are fully booked for months and months on end. And when it's something like a headache, you know, the neurologist won't think it's serious, usually. So I refer them to their GP, but I also make a referral to the neurologist. So they would treat the patient. They would give the patients general analgesics. I do not get involved.
Thank you. There's another question. In the process of doing corneal cross-linking, you can improve vision, isn't it? That the cross-linking is topo-guided, the question. Shouldn't that possibly be discussed with the patient as an option if all variables are satisfactory, especially the thickness, without necessarily raising hopes of improved perfect vision? You can have a look at the question. It's quite a long question, Doctor. It's under question and answer.
No, I think I get the gist of it.
Okay.
You know, in general terms, I'm very careful when discussing corneal cross-linking in making promises that the patient's vision is going to get better. I tell them the primary reason of doing the cross-linking is to stop progression. that's the most important reason we do corneal cross-linking. The improvement in vision, the corneas are expected in successful cross-linking to flatten by 1 or 2 diopters. Right, now, if you have severe keratoconus, that may not make a big difference for you. So I tell them that what will make a difference to their vision would be either spectacles afterwards or contact lenses, always. If their vision improves after cross-linking only, then it's a bonus. I tell them it's a bonus. But patients are, you know, they have unrealistic expectation on the effects of cross-linking on vision. And the biomechanics of corneal cross-linking really are not to improve vision, but to stabilize the ectatic and progressive corneas.
Thank you. Do blue dot cataract progress with age or regress with age?
No, the only cataracts that regress, well, let me put it yes and no. So blue dot cataract is a type of congenital cataract. Congenital cataracts have been found to regress in some instances, though it's not very common. It's about 1% of the cases. So in childhood, it may regress and disappear. There are those where it's stable, so they never have symptoms. And they present in their 30s and 40s, and you find these blue dots, and they're just not bothered by them. However, there is a body of literature that suggests that in some patients, about 20% of patients who have congenital blue dot cataract, it gets progressive over or progressively larger and symptomatic over time. So those are the patients who we would often see with some sort of symptoms, whether it's night vision problems, dark adaptation problems, and those will need surgery.
Thank you. With corneal cross-linking, will the prescription decrease? And what are the chances of improving vision after the surgery from your experience? Or if you can put your success rate where the vision improved in percentages?
Okay, so can I sort of address the underlying question of that question, which I assume? Okay, so people would assume that doing corneal cross-linking with Dr. X versus Dr. Y is better because Dr. Y's cross-linkings are better. Technically speaking, cross-linking is a bit like, it's a set recipe. Everybody should be performing it the same way. I do epithelium off. I use isotonic ribotran, and I do accelerated fluence exposure to UV light. So I would soak the corneas for 30 minutes, and I'll expose the corneas to UV light for 10 minutes per eye at a time. Okay. Now, about 85% of patients would have some sort of flattening of the cornea over time. Remember, you will judge flattening of the cornea over at least 6 months, usually around 9 months, where you can tell the difference. But about 85% of my patients would have a change or steepness, flattening of about 1.5 to 2 diopters, which is considered a success in clinical trials, at least.
Thank you. How many times could cross-linking be done in a patient, and what would the youngest and oldest ages be?
Right. There's not really minimal age for cross-linking. The difficulty is always, will the child lie down long enough for you to do cross-linking for 50 minutes? They need to lie flat still while you do something on their eyes while they're awake for 50 minutes. So some of my colleagues, they've done children as young as 5 years old. I haven't done a child that's young yet. And one of the reasons why I'm inclined to refer them on to a pediatric ophthalmologist is children have naturally thin corneas. So you have a thin cornea naturally, which thickens over time, but which will now become even thinner because of keratoconus. So I don't take those chances. I refer them on to a pediatric ophthalmologist. The second part of the question is, can you repeat cross-linking? Yes, you can. But the success rate of repeat treatment is lower than with the initial treatment. It's thought to be somewhere in the order of 35%, 35 to 40%. And this suggests that those who don't respond the first time are poor responders in general. So even if you repeat it, they may not necessarily benefit. And you usually wait 6 months before you consider repeating it.
Thank you. Does cross-linking also strengthen the cornea since there is extreme thinning in the keratoconus?
That's the whole point. So what corneal cross-linking does at a molecular level is the keratin sulfate molecules in the corneal stroma sort of form new bonds. So they sort of, if you imagine rows and rows of straight line straws, if I may put it that way, that are curved. So when you do corneal cross-linking, these straws suddenly develop sort of side bonds with each other, which makes the cornea stronger. So mechanically, yes, it makes the cornea stronger.
Thank you. Where can one refer patients for genetic testing for rod cone dystrophy?
Rod cone dystrophies. Genetic testings are done in most specialized hospitals. I mean, at Visiomed, would refer the patients to for genetic testing. You know, the issue of genetic testing, it's not necessarily about the genetic test, because you got to remember the genetic test itself costs somewhere in the order of 15,000 Rand in some cases, because they get sent overseas depending on the disease. So usually if a patient has a family member who has the disease, in fact, you ask the patient to bring their extended family for a free consult. You dilate all of them and you have a look in their eyes. And if it's a autosomal dominant condition, most or all of them will have the condition. Genetic testing will play a role in the future where the genetic test results will determine treatment. For now, it doesn't determine treatment. So clinical evaluation is a bit more important than genetic testing. But if the patient really wants to know because they want to have a family, maybe it will affect the decision or impact the decision of whether they're going to start a family or not. You send them to specialist eye hospitals, and then we'll take it from there.
Thank you. Is it common for a patient to experience corneal haze after cross-linking? How long does the haze last? Right.
So patient selection with corneal cross-linking is important. There's two aspects to corneal opacities in keratoconus. One is pre-existing subepithelial scarring, which may be rather subtle initially, and which you may only notice after the cross-linking. So then it becomes, is this corneal haze or it was scarring that existed before? So that you must make sure before that the patient has no scarring, or if they have scarring, they at least have minimal scarring. Now, corneal haze, I must say, I haven't experienced it a lot. I do perhaps about 20 cross-linkings a month, somewhere there. They usually do not get corneal haze. Those who do, if you give them steroids for long enough, it generally gets better. And if it doesn't disappear, then you're really looking at a corneal graft for the patient.
Thank you. What doctor is saying is understandable. However, with topo-guided cross-linking, a keratonic patient corneal ectasia stopped. Sorry, I'm going to ask you to read this one. I'm missing something here. If you go to the question and answer, audience Maluleke, can you see it, doctor?
Yes.
It's the second last question.
Mm-hmm.
Can you read it?
Yes.
Will you mind doing it for me?
Right. So what doctor is saying is understandable. However, with the topo-guided cross-linking, a keratoconic patient, corneal ectasia stopped, and refraction minus 4.75, minus 5.5 cell at 90 degrees, so really astigmatism. The left eye minus 4.5 sphere and minus 4.75 cell. We are just over a year from when this was done, and she was just under 16 years old. We are seeing her, and her refraction is plus 0.25, I think this is sphere, and no cell. I'm curious what this patient's corneal thickness was. Do we know?
Okay, audience, you're welcome to write it down.
Remember, what I want to emphasize is you need to differentiate between the structural aspect of keratoconus and the functional aspect of keratoconus. Okay. The structural aspect, you are not only looking at the refraction, you need to look at other underlying things like stromal thinning, the steepness of the corneas, the location of, we call it a nipple, unfortunately, of the area of thinning. You can get really good results with topo-guided corneal cross-linking. Most patients I see are more than just minus 5 cells. You see like -7, -8 cells. And I don't expect them to suddenly be hyperopic after corneal cross-linking. What I would recommend, which works quite well, is just that it's quite costly, is intrastromal rings.
Thank you. What is the difference between tomography and topography?
I'm glad you asked that question. So topography simply looks at the height of the cornea. So it looks at essentially steepness. Tomography not only looks at the steepness, in other words, height, but you look at thickness of the corneas, you look at the anterior curvature, you look at the posterior curvature of the cornea. So tomography is more comprehensive. So when you're sending a patient for a pentacam, which, I mean, a pentacam is a brand name, you're actually sending them for tomography. Topography is rudimentary, and it only tells you whether there's deepening or not.
Okay, audience answered back when you asked about the thickness of the cornea in the region of 520 to 530, but they need to refer back.
Audience, that's a dream patient. I would like to have treated that patient. My keratoconus patients never come with such thick corneas.
Okay. Are corneas part of the donor list if one wishes to become a donor?
Oh yeah, absolutely. Unfortunately, the rate of corneal donations is very low in South Africa. Most corneal grafts that we procure from the US almost exclusively. It's very uncommon that you will have a South African donor, but they go through the tissue bank, which is really controlled by government. If you want to donate your corneas, obviously you have to be an organ donor, an active organ donor.
So come on, now, optometrist, put your name down as being a corneal or a general donor. With the 40-year-old headache patient, what was your thoughts about her chest pains and body aches?
My initial thought was she she has troubles at school, which she does, which I confirm with the mom. And such patients, teenagers, you're going to be chasing your tail trying to resolve their symptoms. The best thing is to obviously exhaustively examine them, send them to your colleagues like neurologists. They will do scans of all sorts, and they will also send the patient to a pediatrician who will examine the patient. Once everything is exhausted, then you can come back and say, well, this is actually more of a behavioral problem than an actual problem.
Right. Doctor, I think this was all. There was one. I just want to go back to it, if you can give me a minute. Okay, I can't find it now. Yes, I think we could. I think this is it. Is there anybody else that would like to post a question? Otherwise, I think we've covered quite a few questions, and I think, well, we're ready to say goodbye then, Doc. To all of you, I will. Sorry, there are still raised hands. I just want to check what else has come up. I'm not sure where to go with the raised hands. Do you know, Doctor? There's a chat. There's nothing under the chat that I see.
Right.
All right. Yeah, I don't know what the raised hands mean. I don't see any more questions. You're always welcome to email them to me. If I am missing something here, there's one new message. Let me just have a look. Okay. All right. Why would you not do LASIK on a keratoconic patient?
Because you don't want to pay out a large lawsuit. Sorry. But anyway, so remember, keratoconus is primarily stromal thinning of the cornea over time. So the corneal stroma thins and then it sort of bulges because it's so thin. With LASIK, you resurface the cornea and you make it thinner. So you can't make an already thin cornea even thinner. They'll just become more ectatic, they'll bulge more, and eventually they'll get acute eye drops and they'll lose vision and they'll need a corneal graft. So one of the things that we look out for in patients who wish to have laser refractive surgery is that they do not have subtle or early keratoconus, because those are the ones that catch you out. The cornea looks normal, but on certain parameters on tomography, they may be suggestive of keratoconus, which may not necessarily be progressive. So those patients, we generally advise not to have LASIK or PRK or even SMILE.
Thank you. What is corneal thickness limit to do cross-linking?
In the original clinical trials, it was 400 microns. So anything below 400 microns, they would exclude. However, there are ways of, because the reason there is a thickness or thinness limit is that the riboflavin that you use during the procedure is toxic to the endothelium of the eye. So the thinner the cornea, the higher the likelihood that you're going to get toxicity from the riboflavin. So there are ways. I treat patients up to 350 microns where you use hypotonic riboflavin instead of isotonic, which thickens the cornea. It causes sort of swelling of the corneal stroma, and you can safely do corneal cross-linking in those patients. Patients who are thinner than that, I recommend corneal grafts.
I think I've missed one question. It's the third to last question. Sometimes they miss a word or so from Ofalele. From the question raised, if you repeat the cornea cross-linking, does that mean it does not stop the progression of the keratoconus completely?
Right. So
Because,
I think what
yeah,
Pelele is saying is, if you have to repeat it, what would be the logic given that it didn't work the first time round? Right. Now, there's several factors, all right? Some ophthalmologists, even though I say there's a set recipe, strictly speaking, after soaking the cornea with riboflavin, you're supposed to put the patient in the slit lamp and make sure that the whole stroma is soaked through up to the endothelium, just before the endothelium. And you need to make sure that when you expose them to UV light, it's adequate power, and the distance of the light source from the cornea must not vary. In other words, patient mustn't be moving around, the light source must not be moved, and all those things during the full 10 minutes. So the assumption would be, it's not necessarily that the patient didn't respond, it's just that the technique that was employed the first time was perhaps not ideal. So you repeat it, but you can only do it after 6 months.
thank you. Jenny, Sydney, I'm not sure if you, I can't let you talk. If you could maybe put your question under question and answers. I'll just see if she comes through. Okay, Jenny, I suspect, or I suggest just maybe send me an email if you don't mind. Right, as I said, I think let's conclude with this. If there are more questions, please send me an email. You're more than welcome, and Dr. Khantsi won't mind answering them for you. As I said, okay, I will send your certificates probably in the next week. If you didn't receive a certificate by end of, let's say by next Tuesday, please let me know. That basically means that I didn't recognize the device where you spoke from. Dr. Khantsi, thank you very much.
Thank you very much. Thank you all for
attending. I think it was a real nice, down-to-earth, common logic talk, and very practical. Thank you so much to all of you who attended. I really appreciate it. Have a lovely evening. Bye-bye.
Bye.